Morning, everyone, and welcome to Dental Protection. It's dentistry, but not quite as we know it. My name is James Foster, and I'm the head of dental services for Asia and Australasia, and manage cases within Asia, together with my colleague, Dr. Simrit Ryatt, who is with us tonight and joins us, and I'm very grateful to Sim for doing so. She manages cases for South Africa as well, and also works alongside the UK team and the UK cases. We're also joined by Charles Lin and Tracia Lim.
Hello, good afternoon.
Hello. Charles is the founding director of Charles Lin LLC, a law firm that specializes in and is dedicated to medical legal defense work. And Charles has been MPS and DPL's panel lawyer for over 25 years. Tracia is an associate with Charles and has been assisting Charles since she was called to the Singapore bar in 2016. Charles and his team have been a great help to our dental colleagues and ourselves in supporting members locally, and we're very grateful to the ongoing work and the quality of work and support that they provide to our membership. And thank you very much again for joining us tonight. As you will know, I'm sure, we use panel law firms to assist members in country in a variety of ways, and as part of a larger team to support you when needed and to advise along the way, along our professional journey. And it is a vital element and a component of what support we can provide to you. Now, pre-COVID, I would have been traveling at this time, and the plan for me was to be in Asia. And I'm sorry I've missed that opportunity to have met with some of you again and also to meet new members. This is an incredibly challenging time, and as we can see, the virus may pose a threat for a long time to come. It's obviously variable in its presence. We're seeing it up and down all throughout many countries, different levels of sanctions being taken, others being eased. We're here for a long journey, I think, and I wish you all safe and well, and do appreciate how difficult this problem is for the profession. Members of dental protection around the world have been faced with the same challenges of returning to work and creating a safe environment for everyone. The way we work and the procedures we carry out make the dental practice a good breeding ground for the spread of the virus, and we're having to face new ethical and legal challenges as we do so. Tonight, we will address many of the key issues and trying to answer as many of the questions you submit during the webinar as we can, and please refer to your Zoom screen to submit questions that we'll deal with hopefully at the end. The dental profession across the world has had to react and adapt very quickly to the pandemic, and the uncertainty attached to the changes we have had to implement has overwhelmed many of us, and that uncertainty has been the driver for the content of this presentation. Now, the key issues we want to focus on tonight are consent and disclaimers. Consent for treatment and separately the use of disclaimers as a tool to protect you from a patient who wants to sue you for transmission of the virus. That's an interesting area, and we will expand on that, and Tricia's going to help us go through that. Taking that theme forward, we'll also discuss the potential threat of litigation and the potential consequences if you are found to have negligently allowed the transmission of the virus in your practice. Then dental associations in many countries, just like the SDA, have shown leadership through the pandemic and have overseen and supported the development and publication of professional guidance on clinical protocols and indeed those for patients. Also, government have determined what steps and actions we should take and what we should not do. What are the consequences if these rules are ignored or inadvertently broken? We'll explore those. Also, we will explore the potential of an increased risk of complaints, litigation, and regulatory referrals, an increase in Singapore Dental Council cases. How is the impact, what is the impact going to be in that area? We'll also explain the ethical rules supporting the use of teledentistry during the pandemic. Many of us have been speaking to our patients on the phone and will continue to do so in a variety of degrees. How do we cope with that? What can we do? What do we record? And finally, we will discuss some of the key questions around ethical patient management which have arisen in relation to COVID-19. Now, to start with consent, this slide is just a memory jolt, and those of you who heard me 3 or 4 weeks ago, we did cover a whole session on consent. This is just a quick, brief intro, so bear with me. A memory jolt, and highlights the 3 components of the consent process commonly called shared decision making. So information, capacity, and voluntariness. Information, this speaks to the disclosure of relevant information by the clinician, as well as establishing the concerns and preferences of the individual patient. This is a two-way process. Capacity, the patient's ability to understand the information and to appreciate the consequences of their decision. This is the point in the consent process where they cognitively process the information and where you check their understanding. In terms of the voluntariness, there's the patient's right to come to a decision freely. That's without force, coercion, or manipulation. Now, consent is not a tick or a signature, as we've discussed previously. It's an exchange of information. There is a power and knowledge imbalance in the relationship, and the process of obtaining consent requires you to provide and to receive information. Our first job is to listen to the patient. That's active listening without interrupting them, which is not always busy in a busy clinic, and not always easy in a busy clinic. Studies have shown that clinicians are not necessarily great listeners, although we are great interrupters, as we often want to get on with things, do the doing, do the fixing, particularly if the patient is in pain or we have other patients backed up in the waiting room. When we want them to stop talking, we've probably already switched off our listening antenna. This can unwittingly undermine the quality of information sharing and our ability to obtain valid consent. Okay, so communication is a two-way process, but when you look like you're dressed to handle nuclear waste rather than treating patients, things become a bit more challenging. So before we even get to treatment, the first decision a patient will probably make is about attending. Is it safe? You're unlikely to be part of this conversation, but you need to know about it and be alert. Things can go wrong if your team is not properly prepared. If the patient expresses a reluctance to come into the practice for a face-to-face assessment, and where there is clearly enough in the remote history to suggest they should, then the practice must very quickly undertake an assessment of that decision and weigh it against the potential for adverse consequences of non-attendance. In short, you or your frontline staff must be aware of the possibility that the patient may talk themselves out of attending for treatment when they need, and they need to understand the dental and health consequences of not attending. The fact that this discussion has taken place must be recorded. This additional admin burden may seem overkill. However, there are cases where a patient has successfully litigated having been given incorrect triage advice. COVID restrictions place an increased responsibility on those carrying out remote triage, and you must make sure your staff have been appropriately trained and are not delegating responsibilities for which they are not qualified. Now, when we see this slide, we're talking about consent being about options and risk. Now, treatment options should be the same as those available pre-COVID. Should be the same discussed. Identify the preferred patient choice and discuss the impact of COVID on the availability of that particular option. The law requires you to discuss all the usual options and the risks of treatment a patient's condition, for the treatment of a patient's condition, whether that treatment is available or not. E.g., you may not be able to undertake RCT because you've run out of rubber dam, but if you fail to mention this as an option for the patient's pulpitis or periodontitis and only offer an extraction, then you will have failed to obtain informed consent for the extraction. So identify the patient's preferred option, then we have to discuss whether that preferred option is available. The availability of normal treatments may be constrained by levels of restriction or shortages of PPE. At this point, I also want to mention the aerosol generating procedures, AGPs, and how the way information presented about AGPs might inadvertently influence a patient's treatment decision. Until the evidence base gives us proper, robust scientific evidence, we are all exercising caution in the provision of AGPs. The restriction of AGPs serves the public interest in lowering the potential for virus transmission, but the risks that the guidance we see seeks to mitigate the risk that the guidance seeks to mitigate are not risks that apply to the patient having an AGP. Arguably then, the increased infection control protocols and PPE do not necessarily protect the patient undergoing the AGP, and it would then be a failure in the consent process if a patient postponed treatment or selected a lower COVID risk treatment to avoid an AGP in the belief that their choice somehow lowered the COVID risk to them personally. We need to be very clear about why we are dressed like nuclear physicists and look completely different from the last time when your patient came to see you. It's not normal, and it's certainly not dentistry as we and our patients know it. You therefore need to separate out the influence of availability, what treatments you can actually provide that day, in the patient's treatment decision, as this could undermine the voluntariness of the consent process. Now, a signature may be regarded as good practice, but in isolation has limited benefit. The record needs to reflect the consent process in that the information has been provided to the patient which they have considered and understood, but essentially records are important, not just the signature. How do practices deal with consent forms, and can they be signed online? Well, consent is a very wide topic, and it would be a webinar in itself, as it has been, but with regard to a telephone conversation, it would be important to follow the general principles of consent. Firstly, inform the patient of the findings, clinical opinion. Secondly, inform the patient of the reasonable treatment options in circumstances, along with the risks and the benefits, including the risks of no treatment at all. Thirdly, it may be appropriate in certain circumstances to inform the patient that the only reasonable treatment option at this time is an extraction or no treatment at all. Allow patients time to make a decision and advise them of any potential consequences if the treatment is not carried out. Good detailed records of the consent discussion should be made, including what the options were and why, along with an indication that the patient understood and agreed to proceed. In relation to consent forms, apart from areas such as sedation and general anesthetic, there is no specific requirement for consent forms to be used. It is important to note that consent forms are not a replacement for the consent process, but may be a helpful adjunct. More important is a contemporaneous, written at the time of the event, record indicating the consent discussions as I've discussed previously. Consent forms can be useful in providing additional information for a patient to consider, and you could ask a patient to confirm by email, for example, that they have read the information, but this in itself would not be evidence of consent. So with so many different things now in the delivery of care, it's easy to forget or to cut corners in our usual routine. The key message about consent is that COVID hasn't changed anything. There are key questions a patient needs to be able to answer at the decision-making point in the process. Our job is to make sure that they have sufficient information to answer all these questions satisfactorily. Choosing wisely is part of a global initiative to improve the conversation between clinical staff and patient, or the clinicians and the patient in the consent process, and it gives us a short and useful checklist to fall back on when you need a reminder. So it is an Australian version of this, but I do think it fits quite well, and certainly my colleagues in Australia have been using this very widely. So one of the questions we're asked very frequently is, would using a disclaimer be helpful? The idea of a disclaimer is a means of transferring the risk and responsibility for virus transmission from the dentist to the patient and somehow giving immunity to a potential prosecution or litigation in the event that the patient claims such an event occurred. However, there are issues to explore here, and if I might ask Tracia to expand upon these, I'd be very grateful.
Yes,
thank you.
Sure. Hi. Yeah, so would a disclaimer protect clinic from patient's claim that patient caught COVID-19 while receiving treatment at the clinic? But generally, a disclaimer is a statement or a contract that aims to prevent or limit tortious liability from arising. So in the first place, what is a tort? So can I have the next slide, please? Thank you. Right, a tort is a civil wrong that causes a plaintiff to suffer loss or harm, and it results in legal liability for the defendant. There are various types of torts, and in this case, we'll be looking at the tort of negligence. In a tort, there must be a duty of care, a breach of that duty, and the breach must have caused the harm suffered, and the harm suffered will then be quantified into damages. And the question in this case would be whether the clinic owes a duty of care to patients and visitors to prevent the transmission of COVID-19, and whether the clinic breached that duty by negligently failing to exercise proper infection control. And in considering this question, we will look at a few factors. One, has the clinic assumed responsibility for the patient? Assumption of responsibility can be by conduct, as the clinic represented that the place is clean and safe, and by taking in patients and visitors, it's likely that it will be held that the clinic has assumed some sort of responsibility. And then is it reasonable for patients and visitors to place reliance on the clinic to take care? Yeah, it would be, because by telling them, okay, you can come to our clinic, and in such a situation, reasonable patients would expect that the clinic is of a reasonable standard in such a situation for them to receive treatment. Does the clinic have control of risk of harm? Yes, it can, because it's within their control and it's within their discretion to disinfect and clean up the clinic. So patients and visitors belong to a vulnerable class of persons. This, yeah, like any other ones, any other people who visit a place, they are not exceptionally vulnerable, but it's not that it's not that they are not vulnerable as well. So this is more to a certain extent, yes, they are. It's more likely than not that the courts would find that there is a duty of care and that it is foreseeable that patients and visitors would suffer harm if the clinic do not take reasonable care to eliminate the danger of a COVID-19 transmission. The standard is not that you must guarantee zero risk of transmission, but that you must take reasonable care and reasonable steps. Okay, the next question would then be, does a disclaimer have legal effect? Generally, yes, but the terms of the disclaimer must be reasonable and that the other party has the opportunity to review the terms before assuming the risk. It does not matter whether they have actually reviewed the terms, but they have had the chance to review the terms before assuming the risk. And in this case, it will be before entering the clinic. And finally, the terms must not contravene the Unfair Contract Terms Act, UCTA. And we look at UCTA, Section 2, subsection 1 of UCTA states that a person cannot, by reference to any contract term or notice, exclude or restrict his liability for death or personal injury resulting from negligence. That is to say, no one can disclaim liability for death or personal injury. And personal injury is defined under Section 14 to include any disease and any impairment of physical condition. Okay. The relationship between disclaimer and UCTA has been ruled upon. In 2011, in the case of Dentolegal, the Court of Appeal upheld the High Court's decision and held that where a disclaimer takes the form of a contractual exclusion clause, it would be subject to UCTA. In doing so, the Court of Appeal referred to the UK House of Lords decision, which states that disclaimers are subject to the Unfair Contract Terms Act. And so disclaimers are unlikely to provide a blanket protection. What the clinic can do is to give notice of the situation in the clinic to patients and visitors before they enter the clinic. It could either be by text message before the appointment or a notice on the door. Can I have the next slide, please?
Sorry.
Thank you. Yeah. This is especially if the clinic has had patients who were subsequently tested COVID positive or had patients who displayed COVID-19 symptoms. Giving them notice, you should give them notice that they need to pay more attention and be more careful, especially in following guidance on safe distancing and hygiene. Giving notice will go towards taking reasonable steps to keep patients and visitors safe. But giving notice alone is not enough. You still have to follow MOH guidelines, which we will discuss later, and take all reasonable steps to include safe distancing, routine cleaning and disinfecting, spacing out appointments, etc. Next.
I think that's, yeah, that's me then. So just in terms of that, Tricia, thank you for that. We can totally understand the thinking behind, people wanting a disclaimer. But as you're saying, you can't contract out your duty of care, nor can a patient consent to negligence. A signed disclaimer, therefore, is perhaps little value where transmission occurs in a dental setting. Now, contrary to the use of disclaimer, if you're using one, if people have used one, because we've spoken to colleagues who've had it, you may well plant the seeds of doubt into the mind of a patient who catches COVID that the source of their infection was in fact the dental practice, which is the very thing we're trying to avoid. So if you want to reduce the possibility of a patient bringing a claim for transmission of the virus, then you're more likely to achieve this by reassuring patients that dentists have always had to follow strict infection control protocols. You may also wish to highlight additional COVID-related protocols in place, space between patients, fallow time, social distancing measures, etc., and reinforce the message that your practice is a safe environment rather than a potentially risky one as implied by the disclaimer, because dental practices have always been a center for the highest levels of cross-infection control. And I think we take that opportunity to reinforce that rather than have a situation where it's feared as an environment. Now, in terms of perhaps the most common second common question we have been asked is whether we would provide an indemnity if a patient actually attempted to sue for transmission where guidance has not been followed. The first thing I would say is that COVID-19 has not placed any restrictions on the scope of indemnity, and your right to request assistance is unaffected. Access to indemnities do not provide immunity, however, in the event of a patient suing or reporting to the Singapore Dental Council. We do sometimes see colleagues saying, well, if I've got indemnity, then I'm protected. Well, it doesn't stop somebody taking action, but we're there to help if they do. We should, though, discuss distinguish the defensibility of a dentist in the following scenarios. So dentist in case one, dentist in providing cares, followed the guidance, used the correct PPE, implemented social distancing protocols, used remote channels of communication to identify and isolate patients at risk, followed all of the current timely local guidance, because it will change and you should always be making sure you're up to date, then that individual's in a strong position. The second scenario is completely different, where a dentist deliberately chose not to follow the guidance, failed to use PPE, putting themselves, their staff, their patients and wider population at risk of transmission. Such an approach may well be considered deliberately reckless and irresponsible, and would normally invalidate the terms of an insurance. Obviously, we're slightly different. If such a situation arose with a dental protection member, then whilst being indefensible legally, it would also raise question about the level of support a member should receive from dental protection as it amounts to the individual's personal conduct. The Singapore Dental Council would be deeply concerned if their investigation of a complaint alleged poor compliance. The issue of safety is at the top of the agenda of everyone, and there will be little tolerance of compliance failures. If the transmission takes place in the practice but outside the treatment room, then your public liability should be approached. That's your public liability insurance. If a member of staff contracts COVID through a failure to implement the necessary safety measures, then this should fall to employer's liability insurance. So just to clarify, if a claim was brought against a member alleging that through a negligent implementation of cross-infection control, the COVID was caught within the surgery, then please approach us for assistance. So what about a member of staff being infected, or perhaps ourselves being infected? And Tricia, if I could come back to you to expand further on that issue.
Yeah, maybe I should first answer one of the attendees' question in the Q&A box. I'm afraid I'm unable to remove my mask, not because it spreads electronically, but because there's other people in the room and I have got to put my mask on it, so it's required by law. So sorry about that. All right, back to the question, what do I do if I test positive or if one of my staff tests positive? First, can I have the next slide, please, James? Sorry. Thank you.
Sorry.
It's okay. All right, first we can take a look at MOH circular, which states that after referring a suspect case to a GP, there's no need for practitioners to self-quarantine, and MOH will initiate contact tracing if a case is positive and to follow up with the clinic on further measures. Similarly, if a practitioner or a staff is tested positive, MOH will initiate contact tracing. Those who have had close physical contact with or stayed at the same places as the COVID patient are considered close contact, and they will all be monitored closely for 14 days. Of course, the clinic should carry out proper disinfection before resuming operation, and NEA has a list of companies that can carry out disinfection works. The American Centers for Disease Control and Prevention has recommended that staff who has had close contact should be excluded from work and be quarantined for 14 days, even if their test results are negative, as there is a possibility that the individual is asymptomatic. This is a suggestion from America. It's not under our MOH guidelines, but for those who might be interested. Okay. The clinic may want, can I have the next slide, please? Thank you. Right, and the clinic may want to be prepared with the following information when MOH contacts the clinic for contact tracing. So when was the last contact? What type of contact? Were they working in the same shift, in the same area? How long was the contact? Was it an entire shift or was it transient? Approximate distance, and whether these people who are in contact, were they displaying any symptoms? And if you are the one who has been tested positive, then of course you will have to follow the guidelines and orders that were given out by the authorities. James, please. Sorry, James, next.
Sorry.
Thank you. Yes, so this is the one. It has all the guidelines there. And I think that's all for this slide.
Okay. So, okay, Tricia?
Yeah.
Yep. So what we have to consider is what really could happen to us as practitioners if we don't follow the rules. Now, Tricia, I'll ask you in a second to expand on that. And I think there's two elements, aren't there? There's the one that we often forget. There's the legal issue. You know, you draw criticism from the legal and legislation aspect, but of course, if we are then found and criticized through that process, then of course the Dental Council, our regulatory body, would also explore that further with us. So there's the two elements to consider that, you know, someone in the public domain who wasn't regulated by a professional body such as the Dental Council wouldn't face, but we potentially have a double whammy, don't we, if we have a professional regulation. So you have legal and regulatory potential challenges. So if I could ask you just to follow through on that, and I'll try and be a bit better with my slide amending, changing. Okay.
What are the treatments that are allowed during this safe reopening period? Can I have the next slide? Yes. Okay. If we take a look at MOH circular, the main points are that they've got to first triage and prioritize patients with more urgent medical needs. And after that will be the ongoing sensitive cases, time-sensitive cases that are likely to lead to higher clinical risk of potential complications. And physical visits should continue to be avoided where possible. And if you have to have physical visits, the appointment should be spaced out to maintain safe distancing. And last but not least, it's recommended that clinics minimize aerosol generating procedures and prioritize the use of hand instruments. Next slide. Okay, they have provided us a non-exhaustive table of treatments which are allowed during this safe reopening period. The list is non-exhaustive, but there are still certain types of treatments which should continue to differ. For example, in new cases of crowns and bridges. This is available online, but I'm sure if you would like to have this slide, maybe James can send it to you after the presentation.
Indeed, Tricia, and what we shall do is we shall put this up onto our website and our PRISM platform so members can access the recorded version. Thank you, Tricia. Yeah.
No problem. And okay, for the next slide. So in the event you treat a patient, there are guidelines which practitioners should follow. So for patient scheduling and management, try to limit the waiting time at clinics, and take note that clinics should also ensure that crowds do not congregate outside the clinic. Okay, they are advised to see patients by appointment basis. All patients and accompanying visitors should keep 1 meter apart from one another, and patients should, where possible, consult alone with the doctor. If they need to be accompanied, it's best to limit the number to one accompanying person per patient, and patients should be scheduled to allow for complete disinfection of operatories. And MOH has guidelines on the intervals between patients, which we will cover in the next slide. And clinics, yeah, okay. Yes. So first, for infection control, you should follow the National Infection Prevention and Control Guidelines, use appropriate PPE, provide patients with mouth rinse before any procedure. And where using suction, you should use it with assistance and rubber dam. Observe hand hygiene. Should sanitize before entering the clinic, when treatment is done, and also before leaving the clinic. And most importantly, you must keep to the following intervals between patients. That's 15 minutes for non-aerosol generating procedures and 45 minutes for aerosol generating procedures. And even if you decide to move to another treatment room to treat another patient, you should still keep to the stipulated interval.
Okay.
That's all. Yes, James?
Okay, so just in terms of that, thank you for addressing those. So one of the other questions that comes through to us is, are we going to see, members are saying, you know, will there be an increase in dental legal claims? Will there be an increase in cases that is arising? And this is where I would ask Sim, if you might help us to explore this further. So are we going to see perhaps an upsurge in dental legal claims?
Thank you, James. This is a really interesting question, and taking into account the extraordinary and unprecedented situation the dental profession is facing, it's difficult to predict exactly what the impact will be on the claims experience. So obviously, for a period of time, many of you will be undertaking only a fraction of the work you would normally be doing, and therefore the risk of claims arising from the actual treatment and also higher risk procedures will be significantly reduced. What we may see, however, is complaints and cases arising from patients who believe they weren't given the correct advice or didn't receive a referral for emergency treatment when they felt it was needed. So in order to protect yourself in this environment, it's therefore important to make sure your patients receive clear information about how to seek emergency care and advice. Clearly record details of all your contacts with your patients, including full details of the assessment, diagnosis, and advice, and ensure that the advice given is consistent with the current national guidance, like Tracia said before. We also know that emergency treatment can carry a different set of risks when treating a known patient in the absence of historic records. We may therefore anticipate some claims arising from this environment. Set against this, in economic downturns, we have previously witnessed an increase in claims, and we may therefore anticipate a rebound of claims in the longer term due to the financial impact on the pandemic has on the economy. One potential risk may be from patients who end up requiring emergency treatment in a referral centre, who then question the need of the need for treatment or whether this could have been avoided. So we will be constantly reviewing our data to look at the impact and share insights. Naturally, should you receive any challenges from a patient regarding their care, the dental protection team will be happy to provide the necessary support. So moving on to the next question, we often get asked, is there a risk of increased litigation given the restrictions placed on routine dental care by the lockdown? So yes, there is a risk from this patient group who are unable to access care or who had treatment during the lockdown without access to the full services normally available, and who might, for example, not have been contemplating an extraction when they presented with an emergency. There are a number of steps you can take to reduce the risk. As Tracia has already highlighted, in order to be successful in bringing a claim in negligence, the patient must firstly show that the defendant owed them a duty of care, then the defendant had breached that duty of care, and that the claimant had suffered quantifiable harm as a result, which is known in legal terms as causation. So let's look at each of these components in turn. Firstly, the duty of care. It's obvious that a duty of care exists when you have offered treatment or advice on a face-to-face basis or prescribed antibiotics or analgesics. However, you'll also have established a duty of care by triaging the patient, even if that only resulted in verbal advice being given. When discussing a breach of duty, The fundamental principle is that the onus of proof is on the patient to show that the care provided by the practitioner fell below the required standard. The basic standard is that of the reasonable person in the circumstances of the practitioner, and I emphasize the word circumstances. In other words, a professional person must meet the standard of competence of the reasonable professional doing his job. The COVID-19 situation has led to the introduction of guidelines that have severely limited the way in which dentists work and the range of treatment options that are available. This has a significant bearing on what would be considered reasonable in the circumstances. Of course, action that might have been reasonable pre-COVID may not be reasonable under the restrictions or even possible. It's therefore unlikely that you will be found in breach of your duty of care by following nationally determined guidelines, as you are acting no differently than any other reasonable person would have acted in your position. The types of harms that might be alleged include, say for example, the extraction of a tooth that could otherwise have been saved following root canal treatment, obviously assuming, of course, that the tooth could have been predictably restored following root canal treatment, or it could be the drift of teeth or need for root canal treatment arising from an extended period of temporization because it wasn't possible to fit the definitive restorations. Or another concern has been the continued resorption of alveolar bone following the extraction of teeth and placement of implant fixtures. The most obvious and likely to be the most common is where teeth have been lost, where it is alleged they could have been saved. The solicitors are unlikely to be successful in arguing the breach of duty occurred during the restrictions for reasons we have already discussed. What they may do is rewind the clock and trace this history of the tooth pre-COVID. They may find a tooth that had been symptomatic on and off for quite some time and argue that had a more decisive treatment plan, for example, a root canal treatment, been provided before the restrictions came into place, then the tooth might not have been lost. Regarding other problems that may be caused by delay in providing care, what is important is now you can consider returning to work, you should try to prioritize these cases and see them sooner rather than later. We have received calls from members where the practices seem to be concentrating on more routine types of treatment. For those of you who haven't returned back to practice, it's important you are seen to be taking reasonable steps to carry out the necessary risk assessments and developing appropriate protocols and sourcing appropriate PPE from suppliers. This, of course, is all speculation, and only time will tell, but I hope I've been able to offer some reassurance in claims where it is alleged there has been a breach of duty. In fact, when all you were doing was following the guidelines. So, thanks, James. Brilliant. So during the pandemic, digital channels for non-face-to-face communication became an excellent way of undertaking the COVID risk assessment and following up on outcomes with vulnerable individuals. The risk is both we and patients push the boundaries and cut corners where a diagnosis and treatment plan clearly needs face-to-face assessment. The duty of care begins the moment you provide an assessment and advice online. Then there is the risk attached to remote prescribing of medication, particularly where there is no previous relationship with the patient and where there is no access to a proper medical history. Then there is the issue of record keeping and the processing and storage of that data. So what do you do if the patient sends you an image of their mouth? Do you delete it or do you save it? Is it even part of the record? Digital access means there are no international boundaries. If you give advice to patients outside of Singapore, what happens if you're not registered in that country? There are clearly going to be huge changes in the way we interact with our patients remotely. But right now, there are some significant challenges and not enough solutions.
Thanks, Sim. I very much agree. And just if I might ask you to take us forward in treating our patients ethically and fairly.
Yeah, of course, James. So it's fair to say we found ourselves facing some very challenging ethical scenarios. And as the slide shows, it's a bit like the Rubik's Cube. Think of these ethical issues as faces of a Rubik's Cube, where the faces can be twisted and turned to show different ethical configurations. Each day and each patient brings a unique combination of ethical issues which represents the risk exposure at that particular time. Somebody once said that our wisdom is all mixed up. Well, so is our risk during the pandemic. So moving on to the next slide. With the inevitable change to the way in which patient care is delivered, how can patients' expectations be managed? We all know things are very different now with new ways of working, which will mean considerable changes to our patients accessing care. Infection prevention and control is very different, as is social distancing and patient flow through the practice, and remote consultations and triage play a large part in the patient's care. It's really important to manage the patient expectations and prepare them for changes that have been implemented for their safety. The patient experience is going to be completely different, and remote consultations continue to be part of the patient journey. This provides you with a great opportunity to manage patient expectations from the outset. There are various ways in which you can manage patient expectations and maintain confidence in the profession. Communication is going to be key, and I know a lot of practices have already put together a letter advising their patients that it's unlikely to be business as usual for some considerable time yet. In these letters, you could include what measures have been put in place for patient safety and what to expect when they attend for an appointment. This may include waiting outside the practice until called in, answering some screening questions and having the temperature taken on arrival, using hand gel or not attending the practice without an appointment, and attending alone with the exception of children or our patients with carers. A video tour posted on the practice website showing the patient journey through the practice may help ease anxiety, as patients will have a better understanding of what to expect. You might want to consider updating the practice website or social media with your latest protocols, and ensure there is clear signage displayed in the practice to direct the patient throughout. Obviously, each practice will differ, so some may not have the necessary PPE and will just be offering remote care still. Some may be finalising their protocols and undergoing staff training, whilst others are ready to start welcoming patients back. Regardless of where each practice is on their pathway to resuming dental care, I'm sure that patients will appreciate being kept informed so that they have a clear understanding of what to expect and when to expect it. So moving on to some more questions we have received. Can I refuse to see a patient who is shedding the virus but has a dental emergency for my own safety? And can I use lack of PPE as a reason not to see a patient who has an emergency? For both of these questions, if you have a legitimate reason to refuse to see a patient, that is, if your clinic isn't geared up to treat patients with active COVID, or you don't have the appropriate PPE, we would suggest you refer the patient on. Otherwise, they would be in essence abandoned. If the patient is in urgent need of treatment and you cannot provide the treatment for whatever legitimate reason, you might consider referring them to a nearby government hospital. The subject of PPE will be coming up later on, and we will discuss this further. However, keeping to the subject of patients with emergencies, I think we should go over to Tracia, as I understand many patients may not tell us if they are unwell. Thank you, Tracia.
Maybe I should answer some of the questions online first. Yes, first I would like to apologize. The 45-minute interval has been lifted, but the main points in the first guideline, they are still relevant to the extent where, with regards to spacing out, to mouthwash, and prioritizing the urgent medical treatments. It's just that the aesthetic cases, they are low down on the priorities, not that you cannot take on other kinds of cases. That one, I'll have to give James an amended slide on that, and I apologize for the error. Okay, now shall move on to the question on what happens if patients lie about being COVID-19 positive or their symptoms or their travel history. There are two aspects to this, criminal and civil. First, we'll look at the criminal liability. So as of 28 February 2020, COVID-19 is an infectious disease under the first schedule of the IDA. It is also a dangerous infectious disease under second schedule with diseases like Ebola, MERS, plague, and yellow fever, and so on and so forth. So under Section 21 of the IDA, it's an offense for a person who knows or has reason to suspect that he's a case of carrier of a disease set on the second schedule, which would include COVID-19, or to expose other persons to the risk of infection by his presence or conduct. This would mean that patients with COVID-19 have a responsibility not to put others at risk of transmission, and this would include providing accurate information on their travel and contact history. And if they lie about being positive, their symptoms or their travel history, they will be committing an offense under Section 64 of the Infectious Disease Act. James, can I have the next slide? Yes, that's Section 64. So it is an offense under Section 64 to in any way hinder or obstruct or assist in hindering or obstructing the exercise of any power conferred by this Act, or when required to provide any information or document knowing to be false or misleading. So both offences under Section 21 and Section 24 carries a maximum fine of 10,000 and or maximum jail term of 6 months for first timers. Repeat offenders can face up to 20,000 fine and or 12 months jail. In the past months, there have been quite a few cases on the news where people are prosecuted for lying about travel history, and foreigners would also be deported after serving their sentence. So, if the clinic wishes to, it may inform patients and visitors that it is an offense to provide false or misleading information under the Infectious Disease Act. And in the next slide, we'll look at the civil liability. So civil liability this is a novel situation, and there's currently a lack of precedence in Singapore. So we will consider the claims for negligent transmission of HIV and herpes in USA. So first of all, what is the liability threshold? How much must the defendant, who is the patient that passes on the contagious disease to others, know of his or her contagious condition for there to be civil liability? So according to case law, the defendant must have actual knowledge or constructive knowledge of his or her contagious condition. And in the case of Andres, the Supreme Court of Vermont held that patients are required to exercise ordinary care to avoid transmitting STD. This would be similar to our concept of reasonable care. And to establish an actionable breach, the plaintiff must show that the defendant had actual or constructive knowledge that he or she was infected with the transmitted STD. So what is actual or constructive knowledge? Actual knowledge is knowledge as we know it, so direct, clear knowledge. But the problems with the requirement of actual knowledge is that it's often difficult to prove and makes it easy for the defendant to evade responsibility by purposely avoiding knowledge of the condition or avoiding treatment. And therefore, the requirement of constructive knowledge is very important. The constructive knowledge is knowledge that a person is presumed by law to have. And in the case of Berner and Caldwell, the Supreme Court of Alabama described constructive knowledge as one who knows or should know that he or she is infected. In Andres, it's referred to as the knowledge of danger. The Supreme Court of Vermont in Andres remarked that the requirement of constructive knowledge holds responsible those who consciously avoid knowledge of infection, even when they are suffering visible symptoms of a disease. And visible symptoms was an important factor in establishing a case in Andres. We can look at Andres. So the question for the court in Andres was whether the husband should have known he was infected. The facts of the case are that he had an extramarital relationship. The wife was first diagnosed with HPV. The husband had never been diagnosed or never exhibited any symptoms of HPV. He claimed that he had no reason to believe that he had HPV, and he believed that he does not have HPV. The wife did not contest the fact that the husband was asymptomatic, and she had no other proof suggesting that the husband knew he was infected. What was important was also that the wife's expert gave evidence that there's no reliable method of diagnosing men with HPV until symptoms appear. In the lower court, the lower court held that the wife must show that the husband knew or should have known that he had HPV to demonstrate that there was a breach of duty. So the fight before the Supreme Court was, what does should have known encompass? And the wife's arguments were, one, by engaging in an extramarital relationship, the husband knew that he had exposed himself to potential risk of being infected with an incurable infection that he could transmit to her. And two, all individuals who engage in sexual activity should be imputed constructive knowledge because sexual contact is inherently risky. That was the wife's claim. So the Supreme Court rejected the wife's arguments and held that constructive knowledge requires at least some evidence that the husband had reason to know he was infected with an STD. The Supreme Court rejected the wife's arguments because her argument is effectively expanding the concept of duty and knowledge to a marital duty owed to a spouse rather than a duty to avoid transmitting a disease. And there's no support for such duty in tort law. And by the wife's theory, any sexual contact would create strict liability. Okay, but however, the court did not reject the policy arguments for strict liability. It in fact felt that strict liability would increase accountability and it was more appropriate for the legislature and not the courts to impose strict liability. So, Andres was a case where the defendant had no knowledge of his contagious decision, but the next case which we're going to look at, Doe and Rowe, it's the contrary. And we have the next slide. Okay. So the question for the Court of Appeal in California was whether a person who knowingly fails to disclose that he has a transmissible contagious disease can escape liability for negligence in transmission because he believed that he could not transmit to her as long as he was symptom-free. So the answer is that a reasonable person should know that if he or she has a contagious sexually transmissible disease like herpes, the disease is likely to be communicated through sexual contact, and therefore there is a duty to avoid sexual contact with an uninfected person, or at least to warn the potential partners. And if we look at the case, like in this case, the defendant had 3 prior outbreaks, 2 of which were confirmed diagnoses, and he knew that herpes could be transmitted by sexual contact. After knowing of his condition, he did not seek information on how to avoid transmitting the disease or whether he should disclose his condition. And in this case, there was a discussion between the defendant and the plaintiff before they started the relationship. So the plaintiff told the defendant that she does not want to risk contracting a sexual disease, and the defendant replied that, I don't blame you, I do not want one either. But he did not tell the plaintiff that he had previously contracted herpes. He did not disclose his condition, neither did he take any precautionary measures. And in court, the plaintiff testified that if she had known of the defendant's condition, she would have never consented. So unlike the case of Andres, the defendant in Doe and Rowe knew he had an infectious condition and that the plaintiff was concerned about contracting it. But yet he went on to have sexual intercourse on a regular basis for 4 months, and the court was of the view that he had elected to gamble with the plaintiff's health rather than to inform the plaintiff of his condition or to educate himself about the disease. And therefore, the Court of Appeal held that the risk of harm was foreseeable and that the defendant had unreasonably failed to exercise due care to guard against the risk. Okay, in the case of John and Superior Court, in considering whether a defendant had constructive knowledge, the Supreme Court of California looked at the totality of circumstances. So whether under the totality of circumstances, the defendant has reason to know of the infection, and if a reasonable person would infer the existence or would regard the existence so highly probable that the defendant's conduct would be predicated upon the assumption that the fact did exist, then there would be constructive knowledge. We have the next slide, please. Okay. And the Supreme Court actually provided a list of factors which they would consider. So whether the harm was foreseeable and how certain was it that the plaintiff suffered harm, the connection between the defendant's conduct and the plaintiff's injury. This is effectively about causation and remoteness, the moral blame, policy reasons, and consequences to the community, and the availability and cost of insurance of risk. So where does this take us in terms of COVID-19? There's currently no ruling on this issue, but considering the cases which we discussed, we are of the opinion that there would be a duty to take reasonable care not to transmit COVID-19 to others. The question is likely whether the defendant had actual or constructive knowledge that he is a carrier of COVID-19. Has there been a diagnosis? Was he tested positive? Or is he showing any symptoms consistent with COVID-19? And what would constitute a breach? Lying about diagnosis would likely be a breach of the duty. Lying about symptoms, possibly, but we also have to take into considerations that these symptoms are not unique for COVID-19 only. So it's not a definite answer. As for lying about travel history, it would be an uphill task establishing that he has breached his duty, because traveling to a country with high numbers of COVID-19 cases does not mean that the person has contracted or has been transmitted COVID-19. It's actually similar to, putting strict liability on the sexually transmitted disease cases.
It's interesting, Tracia, isn't it? Thank you for that. The issue about would you sue someone who you thought had given you or your staff infected with the virus if they cause an infection, and whether, just chatting about the process of litigation, proving causation would be an absolute nightmare really in that situation, and also the process itself, the fact that a healthcare clinician is suing a patient. I mean, the damage, and it's starting down that journey that you might start down and actually regret in the long run. Would you agree, Tracia? It's going to be such a difficult process that, and what are you hoping to achieve if that happened? So I would urge caution in that regard, as you might as well, Tracia.
Yeah, and especially because for this virus, you can catch it from another person who is asymptomatic. So it's really hard to prove where you actually caught the virus, and that even if this person who has COVID-19 attended at that place, you have got to prove that his breach caused you to be transmitted with COVID-19. If you can prove the breach, and if you can prove that breach caused your particular harm, then we can talk about damages, which is more straightforward usually. Yeah.
Okay, thanks. Then Sim, if we could come back to you for about the PPE you mentioned.
Yeah, of course. So lots of dentists are concerned that they're being asked to work without appropriate PPE, and they're wondering what to do. So using the correct PPE for the particular clinical procedure you intend to provide or will be involved in providing has two purposes. Clearly, you'll be concerned to protect yourself from any risk of contracting COVID. At the same time, in protecting yourself, you're protecting your patients from potential onward transmission of the virus. So this should be taken into account into your practice's standard operating procedures, and the guidance in all countries is clear. You must use the appropriate PPE, it should be properly fitted, and you should be trained in its use. I can appreciate it's not always easy to express your concerns in these situations if they transpire. It might be that your practice, like many at the moment, is struggling to get hold of enough PPE. In the first place, check your understanding of the correct level of PPE for each clinical circumstance. Are there other ways of making sure the patients can get the care they need? Can treatment be delayed, or can the patient be referred to a designated centre? If it's not possible for you to manage the situation yourself, let your practice manager know, or practice owner know, or employer know, and defer treatment if if possible. So to continue regardless would in any case put you at risk of challenge, and even if you are indemnified to carry out the planned treatment, even with dental protection standing by your side, it might not be possible to defend your actions. On the other hand, regulators such as the SDC are likely to accept that refusing to treat a patient when you consider it's not safe to do so is a matter of professional judgment, and it's unlikely that you would be challenged. Thank you, James.
Thanks, Sim. So when faced with ethical dilemmas, sometimes we can make poor choices on the spur of the moment, and afterwards we will try and justify what we did, which is a form of situational ethics, and we must be guarded against this. Never before have we been faced with ethical decision making that could potentially lead to the death of a patient if we get their management wrong, or even our own death and the loss of the business. Ethical decision making during the pandemic has such serious consequences, and no more is it only the patient's best interests that are paramount. Right now, we all need to focus on self-preservation as well. Self-sacrifice is the stuff of religion, Shakespeare dramas, and stirring epic films. Self-sacrifice is not the stuff of frontline healthcare, and most of us join the healthcare profession not to risk our lives, but to save others. We would suggest guidance is not there as punishment. It's there for safety and self-protection, and it's changing constantly all the time. So we need to keep up to speed with the latest and keep eyes on what is happening. Never before has risk management meant so much, and never before has our ethical decision-making had to take into account so many variables. So it's dentistry, but definitely not as we know it. Thank you very much for your attention, everyone. We'll have a look. We're very conscious of the fact it's just run over the hour. We have had one question which I will ask very briefly, and that's a colleague who's saying, are they able to refuse to see somebody who has had COVID but who has now recovered? Tricia, would you be able to comment on that?
Maybe I'll pass it over to Charles who attended the
Please,
question.
yeah.
Do I see?
Yeah, you can see.
Hi, Charles.
Hi, James. Hi, everybody. I'm Charles. Okay, James, can I just trouble you to repeat the question again?
Sure. So a member is asking, they're aware that a patient has had COVID and has now recovered and wants to come into the surgery. However, our colleague does not want to see them. Can they refuse to see them on the basis that they've had COVID?
I think on the safe side, yes, you can refuse to see the patient, but you should refer the patient to the NDC, where they have all the safety facilities there.
Yeah, if the patient's fully recovered, is there the evidence, the basis to refuse to see them though? Because if they've had it and they're fully recovered, then it might be that they are not presenting a risk anymore. I wonder
the question is, we know that there are second waves and third waves, and patients who are recovered may still be suffering from the actually maybe still be suffering from COVID-19, not fully recovered. So
right.
To play on the side of safe, you cannot ethically refuse to treat a patient, but ethically you can also refer the patient onwards to facilities that are more able to cater for this category of patients. So I think you can say no, and if I can confidently say that if the patient complains to the SDC, we will have a good defense.
Right. Okay.
But you must refer the patient, offer to refer the patient.
Yeah, it must be I mean, any of these situations, you've got to be a signposting. You can't just leave them high and dry. You have to signpost and take it forward. And I guess as things progress, I think we're going to come across more definitive advice as we establish length of infectiveness, nature of the disease, and it's all going to progress forward. But it is going to be here for a long time, I'm afraid. And talking of which, we've been here a long time. We've run into your evening, everyone. It's now past 9 o'clock at night. I would just like to thank Sim for joining me, and naturally thank Tricia and Charles for your inputs. We're very grateful to your ongoing work and ongoing assistance and support for our members here in Singapore. Sim and I will get back to our casework, and you guys enjoy what is left of your evening. Please do look at our website where our contact details are there, any questions, and there is Prism and a lot of material there for you to look at. And I hope that we can meet face to face someday soon, but it may not be just around the corner. Thank you, Charles. Thank you, Tricia. Thank you, Sim. And thank you
for
attending. Goodbye. Take care.
Take care.